And so probably worth disclosing that the work was supported by MyO1, but this is done by the independent team at the YHEC, who are excellent, as you say. And the aim was really to determine the estimated cost effectiveness of continuous pressure monitoring in a hypothetical cohort of patients with a fracture of the tibial diaphysis. So we're still talking about tibial diaphyseal fractures. So the team at the YHEC created what's known as a decision tree model structure to capture the 60-day costs and health-related quality of life following one of these injuries. And all the analysis were performed from an NHS perspective, and they were determining using a hypothetical cohort of 1,000 patients, as you say, and they're basically comparing continuous pressure monitoring versus our normal standard care, which is clinical assessment, which we've just discussed. And I think some of the key sort of findings from that were that if you utilise continuous pressure monitoring, you save just over £250 per patient. When compared to standard care, you save over 4,000 bed days, which is a huge amount of money and hugely important, particularly in our stretched NHS, as you pointed out, Jonathan. But it also has benefits for the patient as well. There's a quality gain or a health-related quality of life gain for the patient, which also by NICE guidance. So as some of you may know, NICE put a health-related quality of life or a cost effectiveness to everything, which is related to that. And usually it's about £20,000 per QALY. That we look at for an intervention to be
adjusted life here, just for people who don't know.
Yes, absolutely. Yeah, absolutely. And it was what's known as a dominant incremental cost effectiveness ratio, which means it fits within that cutoff that NICE define. And then there's some further analysis was sort of done, so adjusting for maybe the diagnostic accuracy, because obviously this is a hypothetical model that draws data from lots of places from the literature. And even when you adjust for potential differences in the diagnostic performances or a time horizon, it's just as cost effective, or if not more. And that's despite the fact that monitoring is more, the upfront costs, if you like, are a little bit more expensive, or more expensive than clinical symptom signs alone. And I think that's particularly interesting because I think it really adds the cost effectiveness data that has not really been there before. There's been and we don't have any sort of non-hypothetical models really for this because it's quite difficult. But if you think about some of the medical costs that are associated with these, if you miss them as well, then I think it certainly shows the overall benefit and cost effectiveness of monitoring as well.
Yeah, just one other point about that. I've heard it said that, well, if you're concerned, do a fasciotomy. Big deal. If they don't have compartment syndrome, it's just a fasciotomy. It's not without its implications, is it, a fasciotomy?
No, that's right. I mean, there is conflicting data about that in terms of the effect of a fasciotomy on outcome. But I think we'd all agree that you'd rather not do that to the patient, certainly not do it unnecessarily. And what was interesting about the YHEC model is that actually that is where the money is really saved. It's actually on the patients who you do an unnecessary fasciotomy on. That's where you really save money, and particularly on things like bed days, because they can be discharged home earlier. And I think that's one of the key parts of that as well.
Interesting. So we've got France, Canada, and the US of A represented here. I know the numbers, the individual costs of individual elements of healthcare are different. I worked in America half my career, but the principle's the same, right? Milan, do you want to jump in first?
Yeah, I mean, I guess you're familiar, America's moving very much towards value-based care. And certainly for the kind of stuff that I do, that really means bundled payment models. So the hospital's going to get one fee for care of a patient who presents with a tibia fracture or whatnot. And, the margins that the hospitals make on treatment of that patient is going to depend on controlling costs. And one way to control costs is to reduce complications, which can increase length of stay and result in multiple returns to the OR. And as Andrew pointed out too, in this scenario that we're talking about, unnecessary fasciotomies also add to the cost of care for that encounter for the patient and eat into the hospital's, we call it profitability. So it's kind of both sides of this, which are important. Misdiagnosis doesn't just imply missing acute compartment syndrome. It also implies misdiagnosing an acute compartment syndrome in a normal leg.
Interesting. Thierry, do you want to jump in?
Well, I think that Andrew made some kind more or less exactly this summary of what we have to face, exactly the same problem. the amount of the length of stay that is added just because of an acute compartment syndrome and fasciotomy will be one of the main markers to be able to get some reimbursement from any type of devices that will make the continuous monitoring of the acute compartment syndrome. And it's you cannot do that with a polytrauma patient because they have a lot of different other additional injuries, so that the influence of the continuous monitoring is not so high. So you have to select only cases where you have very limited amount. It's only a leg fracture, very similar about that. And well, we are trying to do this survey with the French Trauma Society just to more or less exactly on the model Andrew spoke about, that just to be able to give details to the social security system. As you know, we have a complete social security system in my country that helps, but to get the reimbursement of the product, we must be able to show that the amount of money that we will be able to avoid to spend is based on that. So we need to do more or less exactly the same study that Andrew spoke about. That's
yeah. You know, it's interesting, isn't it, that as doctors, we are trained to and commit our lives to treating individuals, yet nowadays we have to think about things on a population health and cost health basis, which, Pat, you know, I understand it's a necessary evil. Did you have something you wanted to jump in with, Ed?
Yeah, sure. I agree with Terry. Like, it's very, it's much easier to see an experimental model on single limb trauma, but we looked at the national database, the American College of Surgeons, for the TQIP data, and we could see that if you had a fasciotomy, you spend an extra 8 days in the hospital. If you had a fasciotomy for a vascular problem, you spend 16 extra days. If you had a fasciotomy, there was a 13% chance of a deep infection, and there's a 1 in 20 chance of you having an amputation. So those would all add morbidity even to a seriously injured patient, you know, ending up with an amputation you missed. So we think continuous pressure monitoring is a good tool for all those patients. And I think, Jonathan, you mentioned ECMO before. I mean, there's 8,000 ECMO cases done in the US every year. 50% of them end up with fasciotomies. And almost, I don't have the exact number, a lot of them get amputations and morbidity from that. So there is a lot of indications to use continuous pressure monitoring for sure.
It's interesting that, you know, going through my training in Britain, you had to do a little bit of everything, and I did a little bit of neurosurgery. They were measuring the pressure inside the head donkeys years ago. And as a general surgeon, you know, looking and doing colorectal work, looking after people with horrible acute abdomens, you know, nursing them with a laparostomy because we didn't want to close them, or we couldn't close them. So I think you guys are at the forefront of a field change in the way orthopedic surgeons are thinking about closed injuries.